This is a 10-minute webcast for GPs and other health professionals. It features excerpts from a series of talks given by cancer specialists to GPs in Tower Hamlets in 2011. The talks coincided with the launch of the Small C Public Awareness Campaign. The aim of these talks, and the Small C campaign, is to improve the early diagnosis of cancer. This webcast is about lung cancer. The speaker is Simon Lloyd-Owen, respiratory physician at Barts Health NHS Trust.
Thank you. So today we're going to be covering lung cancer and how we can improve the early detection, and hopefully that will lead to an improvement in survival. So just an overview of what's happening in the UK. Lung is the second most common cancer in both women and men after breast and prostate respectively. But although it's the second most common, it's by far the most deadly. So the mortality from lung cancer far outweighs all the other cancers. So clearly there's a problem. This shows the incidence by age and gender. So the blue is the men and the pink is the women. Clearly there are more male cases at the moment. And you'll see it's really a disease of the over 40s. And that's important when we think about what we do with our patients when they present to us. So if you take-home message, it's a disease of 40 plus, almost always. This is the rates from sort of mid-70s to date. And you can see the rate in men is gradually falling, whereas the rate in females is gradually increasing. And this really reflects sort of smoking patterns. And this is interesting for our area because the rate also goes up the more deprived the area in both men and women. So least deprived down here and most deprived up here. We're probably somewhere 19 and 20 in Tower Hamlets. You can see our rate is much higher than the well-off and least deprived areas of the UK. This is a very brief and not complete guide to staging. Stage 1 is basically just the tumour within the lung itself, no nodal or metastatic disease. There's 1A and 1B, it depends on the size of the tumour. Stage 2, it's normally because of nearby nodes are involved, so usually hilar nodes in the same area as the tumour itself. Or it could be invading local structures like the chest wall, phrenic nerve and things like that. So stage 2, local spread. Stage 3 really means that it's also spread to mediastinal or distant nodes. So mediastinal are ones right in the centre of the chest, such as these ones, or it's spread to nodes perhaps in the neck or elsewhere. And stage 4, I'm sure you know this, is any sort of metastases, and that in the new classification that also includes pleural metastases. And clearly survival is linked to stage, and this is data from the Department of Health showing the different stages of lung cancer. I'll show you what the different stages are in the next few slides. But generally, stage 1 obviously has a much better prognosis, a mean survival of around about 8 years. And then as you go down the further stages, much worse prognosis. So stage 4, 5-year survival, only 2%. Stage unknown, really, it's patients that are too unwell to fully investigate. So they're likely to be, again, stage 4 or have comorbidities, which often lead to poor mortality. So that's why their 5-year survival is also very poor. And then if you think about all the stages of lung cancer, only 8% of our patients are surviving more than 5 years. And just to reflect a little bit about what treatments they would get as a consequence of their staging, clearly those with stage 1, we would like to do curative resection, and most of those did. The ones having active monitoring or BSC, best supportive care, had a lot of comorbidities and unfortunately weren't fit for surgery. There's one patient like that who had radical radiotherapy. So the majority of stage 1 will have hopefully curative resection. But when you get to stage 3, the options are really for palliative radio and chemotherapy or best supporting care if they're not fit for those therapies. And stage 4, clearly the majority are having best supportive care, so end-of-life palliative treatment. Some will be having some palliative chemotherapy, and if there are specific symptoms they're presenting with, such as bone pain and so on, they may have some palliative radiotherapy. And this is interesting. The survival is, as we would expect, very dependent on the presentation, where the referral came from. So did they come from the GP, either 2-week wait or other routes? If they did, the survival was 60% or so. They came in via an emergency, 40% less than. So clearly these are definitely patients presenting late. Why do patients present late? Difficult to know, but we do know that they do. And one study showed that at least half had symptoms for more than 14 weeks before they presented. So that's a lot of time for this cancer to become more than stage 1. Those living alone, perhaps because they haven't got their partner saying go and see a doctor, those with COPD and those with longer smoking histories often had greater delays. And that's often because the symptoms are non-specific or similar to the ones they have already, such as cough and breathlessness. So just to conclude that part of it, clearly it's an elderly cohort we have here, a high percentage presenting to emergency department rather than a GP, often presenting late. About 20% of our patients do get surgical resections, and as you've seen, good survival in stage 1 but poor stage 4. And if they come by you, they tend to do better, and I assume that's because you're picking them up earlier. So how can we improve that? Well, clearly there's a few stages that have to happen in order for a patient to be diagnosed. Firstly, the patients have to be worried and recognise that their symptoms are abnormal. And that's where this big campaign about looking at cough in particular is very important. They then need to be prompted to seek advice with you and you to do appropriate, timely investigations and referrals. So just an example of a type of study that's going on in America at the moment. So basically they do low-dose CT scans in at-risk men. So in this particular study, 60 to 75 with a 20-pack year smoking history. And there have been early reports showing there is a mortality benefit for patients going into these low-dose CT screening studies. But we need longer-term data to prove that that's an ongoing advantage. Clearly, there are problems related to screening programs. A lot of cancers we would never know about unless we pick them up, and they may be very, very slow growing, and patients may die with them of something else. And clearly, we're going to pick up more of these. That gives you a sort of bias. Also, there's a lot of further investigations these patients might have that they wouldn't have had otherwise, some invasive, and also psychological morbidity associated with worrying about this nodule. And that you need a huge infrastructure, depending on how big your screening program is, with scanners, radiologists, that sort of thing, to run a screening program. So I think realistically we're at least 5 years away from a screening program for lung cancer. So just looking at the NICE guidelines in terms of when GPs should refer, there are 2 situations in which you should refer immediately. So that's phoning the medical registrar on call. And that's signs of superior vena cava obstruction or stridor. Those patients you should refer after an X-ray. Clearly, anything suggestive of lung cancer on the report, a new unilateral pleural effusion. And this is our chap with the community-acquired pneumonia slowly resolving consolidation. So if after 4 to 6 weeks, a repeat X-ray shows continuing consolidation, that suggests there may be some sort of central lesion obstructing the resolution. And then last slide, normal chest X-ray. But if there are symptoms highly suspicious, like persistent hemoptysis, or perhaps significant weight loss, those sort of things, even with a normal chest X-ray, if you're suspicious, we need to see them. When do we do a chest X-ray? Any hemoptysis, that's difficult because I know we all see occasional patients, particularly young ones, with a little bit of blood specks in their sputum. That's about clinical decision-making, really. But I think any significant hemoptysis, particularly in our at-risk group, over 40s. Clearly new clubbing, new lymph nodes, and then it says unexplained or persistent other symptoms, and it lists there chest, back, shoulder pain, breathlessness, weight loss, hoarseness, and cough. What do we mean by unexplained and persistent? How long do they have to last for? Can we explain them other ways? So I think persistent should be at least 3 weeks for our low-risk groups, but the index should be lower, possibly, so maybe not even waiting 3 weeks if they're presenting earlier, for current and ex-smokers, COPD patients, those with a history of asbestos exposure or previous cancer, particularly head and neck, which can spread. So unexplained and persistent means at least 3 weeks, but possibly earlier for your very at-risk group and clearly COPD patients.
That concludes this webcast on lung cancer. This is part of a series of 10 webcasts available at this address. The Small C campaign aims to improve cancer survival through better public awareness and early diagnosis in East London. You can find out more at this address. And you will find more useful information on these websites.